Welcome to AETCM, the Emergency Medicine Channel.
Yeah.
A 68-year-old female patient came to our ER with alleged history of RTA, fall from scooter with head injury. Okay. Initial 10-second assessment, patient was conscious and oriented. On primary survey, airway was patent. There is no pooling of secretions. Breathing part, air entry bilateral equal. Saturation 97% room air. Respiratory rate is 18 per minute. Circulation part, heart rate is 96 per minute. BP 130/70. CRT less than 2 seconds. Disability, GCS is E4, V5, M6, and pupil is 2 mm bilaterally equally reactive. Exposure given to prevent hypothermia, and GRB is 176. And pain score, it was 8/10. So at that time we given injection PCM also.
Okay. Fine. So
68-year-old
lady, mechanism of injury, she was a pillion rider.
Non-helmeted pillion rider. Going with his daughter.
Okay.
She speed breaker, faster going with the speed breaker and fallen to the right side.
Fallen to the right side, and after the trauma.
That time there is a LOC for 15 minutes.
LOC, that we can come to the sample history. Okay. So on coming to the ER,
there is a hematoma in the right parietal region with active bleeding with a lacerated wound.
Okay.
That time she is a little bit confused.
Okay. Airway patent.
Airway is patent.
Cervical spine.
No cervical spine tenderness.
So whether cervical spine, this thing is protection is needed or not for this patient. Whether you will put a C collar or not for this patient, yes or no. Safer to say yes. If you say no, also I'll ask. Yes, also I'll ask.
In this patient, patient will come with walking with no any abnormality. Normally, when we high dangerous mechanism, we will put C collar, Philadelphia collar. It is better to put Philadelphia collar.
Better. My question is yes or no. Whether you will put cervical
patient
collar.
Came to our ER with walking.
Walking, okay.
Then there is no posterior cervical tenderness, no altered sensorium. There is no
altered sensorium.
No altered sensorium.
At present.
No intoxication. There is no distracting injury.
No distracting injuries. Pain score of 8/10.
Normally in this kind of
pain score of 8/10, and there is a lacerated wound, active bleeding that is coming.
This patient we put.
Yeah, that yes or no. That is my question. See, this is again. If you say yes also, if you can say, but it's always better to put a C collar. That is the safer option. Safer option, whenever you have doubt in mind, go ahead and place the cervical collar. So that is my answer for this. So as you said, the patient was walking. There are a lot of things we can say the patient doesn't need a cervical collar. By stating these things, the patient was walking, she came to the ER, there is no posterior cervical line tenderness. But at that time, you said no distracting injuries. That I cannot accept. And again, the most important thing was a mechanism of injury. Mechanism of injury is what? Where is the injury that she is having?
Right.
The lacerated wound is the
right parietal
region. So the right parietal region going and hitting on the floor, there is every chance that she can be associated cervical spine injury. So around 10 to 20% of the chance that she has got a cervical spine injury. So unless and until you rule out radiologically, unless and until clinically you can rule out. But radiologically, it is always advisable in this case. I'm not saying for every head injury or every other patient coming with trauma to the ER, but in this case specifically, by looking into the mechanism, and there is another distracting injury that the patient is having an active bleeding, and being a head injury, there is always an associated chance of a cervical spine injury of 10 to 20%. You can take into that account. Always better to put a cervical collar on your initial phase, and after you rule out, you can definitely remove. So always you can tell this criteria, the patient is conscious, oriented, she is moving 30-40 degree. That all you can do. Maybe initially our intention is to not to say who doesn't require a cervical collar, to see that after that maybe your secondary survey everything is done, then you have some time, then you can go and reevaluate the patient. You know that the last 20-30 minutes how the patient is in front of you. You are given an analgesics. Then you can reassess the victim. The pain has subsided now. Then you can go and reassess the victim whether she. Then at that time maybe you can remove the cervical collar. Ideally, what I prefer maybe radiologically in this patient. After 30 minutes of assessment is what I will take a call. Whether that patient genuinely requires a collar, whether it can be removed or need to place it. So it always a good practice in the pre-hospital setting especially. But when you tell pre-hospital setting in India, it's hardly, we don't have any very good pre-hospital setup. But at least when they are, the most crucial period is when?
Initial time.
The most crucial period is when the patient is being shifted from that vehicle to our emergency bed. That is the most crucial period. So that time you have to make sure that she is having cervical spine protection, because we don't know any history, we don't know. We just know that somebody has a head injury, bleeding from the head has been brought. I think this patient has been brought in an auto rickshaw to the ER. She has been brought in an auto rickshaw in ER, lying on the floor, and where we manually stabilize the spine and taken her to a emergency room bed. So it's always a better idea to protect the cervical spine in the initial phase and take it as a home message. Like whenever you have doubt in your mind, whether needed or not, always put. That's a simple thing that you need to remember. And again, if there was no any external injury, there was no history of any LOC, the patient is completely conscious. This patient was again not fully conscious. She's having some confusion was there. So at that time,
also for 15 minutes.
15 minutes was there. At that time, how much your clinical assessment of tenderness is going to help is a doubtful question mark. So it's always better, go ahead and put the C-collar and then you make the assessment. Okay, so that is the first part. So airway with cervical spine stabilization. Airway, the patient had patent airway and cervical spine stabilization we have done. Then coming to B, her respiratory rate what's?
18 per minute.
18 breaths per minute, and there is no hypoxia as such. So do you suspect any such chest injuries from the history that you are getting from the mechanism?
By the mechanism, head was hit on the ground. There is no chest tenderness not there. And
Initial assessment. So at present, we are not suspecting any life-threatening chest injuries. I can place it that way. Life-threatening chest injury, maybe an isolated fracture, maybe a soft tissue injury can be there, but a life-threatening chest injury at this moment is not there. So our concern is to look whether to look for life-threatening chest injuries. What are the life-threatening chest injuries that you need to look in for?
In trauma case, there is rib fracture, flail chest, tension pneumothorax.
The fracture is no.
Tension pneumothorax.
Tension pneumothorax, I agree. Okay. Cardiac tamponade. Okay. Massive hemothorax. Massive hemothorax. Then rupture to the great vessels. The patient can have rupture to the great vessel. So when will you suspect in a chest injury victim that is coming to the ER a rupture to the great vessel? When will you suspect? You said rib fracture, but only rib fracture. But when there is this rib fracture and there is something else, I will suspect a greater vessel injury. So which rib fracture you need to consider? You have to see upper rib fractures, especially 2 and associated clavicular fracture. So there is a clavicle fracture. Usually, where does the clavicle break?
Middle 1/3, thinnest portion is
middle or lateral?
Lateral one.
It usually happens in the lateral end. So if you are suspecting a fracture over the medial side of the clavicle, you are seeing a clavicular fracture on the medial end. And because usually there will not be any fracture, because that is not the thinnest portion of your clavicle. Thinnest portion is more laterally. There is more commonly it gets fracture. You are seeing a clavicular fracture here, medially. Then you are seeing 2-3 fractures. And there is a probable significant sternal tenderness and all those things. And there is hypotension. So always in those group of patients, you have to suspect a greater blood vessel injury. So that is the life-threatening injuries that you need to. So what I can say, there is no evidence of any life-threatening. Whatever is a simple fracture, you said regarding flail chest is again life-threatening. Whatever against you say simple pneumothorax, all those things will not come under as life-threatening. So from B, we have made out sure that there is no life-threatening chest injuries. Coming to circulation. So challenges in the circulation. What are the challenges?
Hypotension, loss of blood hemorrhage leads to hypotension and tachycardia. So in that part, if there
so what was the heart rate?
Heart rate is 96 and BP is 130/70.
130/70. So she is not in hypotension. That is one thing I can say. Maybe she might be, we cannot say it's a class 1 hemorrhage. Maybe we can put it as a class 1 hemorrhagic shock because there is no hypotension, minimal tachycardia. But class 1, class 2, somewhere in between, that might be because there is no hypotension. That capillary refilling time?
Less than 2 seconds.
Less than 2 seconds, okay.
Disability part.
So, but there was an active bleeding from the hematoma. So, what will you do at that point of time?
Point of time, we will compress with a large bandage to decrease the active bleeding. Then initially we suture the wound to decrease the bleeding.
Okay, so my question is that if you suspect a skull fracture, whether you will suture or not? My question, there is, you are seeing a depressed skull fracture, okay. There is also a scalp, there is a huge bleeding that is happening in the scalp. And the patient is in class 1 or similarly, class 1 or class 2 shock. Whether you will suture or not.
Huge bleeding there.
See, primarily our intention of putting suture is to stop the bleeding. So, if you are able to do that, you can do. But our intention is not fracture, let it be there. That needed to be explored, or whether they can remove the suture and they can re-explore. But actively, if there is a bleeding, it is always suture. Preferably, because scalp is again a very high vascular area. So, it's always to do a suturing, or maybe you can just give a good compression. And most importantly, what is the commonest mistake that we will do after doing compression? What's the commonest mistake that we'll do after doing compression? What we are doing, what not we are doing, other people will come and do. They will start examining the wound. Yes. After compression, you call your neurosurgeon or you call your general surgeon. So what they'll start removing this. So they make sure that that wound is being kept untouched for at least 30 to 40 minutes till the bleeding is stopped. So what will happen? Whatever the clot formation has occurred, when you are removing it, totally it will be lost. So unless and until it is not going to change a huge decision making. Whether the suturing is all being done, it's not a cosmetic area. Our aim is to prevent the bleeding. So maybe later on, once everything is in better on a controlled atmosphere where all your equipments are ready, then maybe you can remove and see. But that is one common mistake. Like you have given a compression, and after you are given for a consultation, the neurosurgeon or maybe a general surgeon coming and removing it. So that should not be allowed. So always better that you make some good tight dressings, and clear instructions has been given not to touch. If whatever wound that you have, you tell them this is a wound that you have seen, and you can document. Maybe a picture also you can take and keep it ready, so that this sort of repeated openings can be avoided. So that is one crucial thing, to stop the bleeding in this case initially. Then circulation, coming to disability. So disability, where will you place this patient's GCS? So by placing the GCS, we will know what is mild, moderate or severe head injury.
No, with GCS we classified less than
for where will you place this GCS for this patient?
Mild head injury.
Oh, so what is the GCS? 13, 14?
13, 14.
Okay.
Up to 14 to 15, mild GCS.
Okay.
9 to 13, it is moderate GCS.
9
moderate
to 12, you can tell.
Less than 8 is severe head injury.
Less than 9, it is severe head injury. 9 is less than severe head injury.
So in this case, 14 is the GCS.
GCS, so it's a mild head injury you are suspecting. So mild head injury you have suspected, you have protected the cervical spine, you have started the pain management. What is the next step that you wanted to do?
Next step to adjoint to this.
Adjuncts to the primary survey. What are the adjuncts, or along with the primary survey, what else you wanted to do?
We put a IV fluid.
Two large bore IV access. Two large bore IV access needed to be secured. Then
ABG, VBG.
Blood gas or anything. Okay, fine.
Then GRB is also.
Okay.
The cause for the.
Okay.
Then CT imaging.
Before that, fast.
Fast.
Focus assessment sonography in trauma. So that is actually, I will say that is your part of your primary survey. It's not an adjunct to your primary survey. It is your D, and the next after A, B, C, D, E, it is UST. It is UST. You have to make sure that you are doing it accordingly, or maybe with C itself we can ask for an ultrasound. So that is how important is your ultrasound in the trauma. Focus assessment sonography in trauma has to be done. And next thing, as you said, our priorities. If you ask me, do you want a chest X-ray? Yes, maybe yes. You want a pelvis X-ray? Yes, I need a pelvic X-ray. But my priority for this patient will be to get a CT brain plane along with an CTC spine also. That is what I will ask for. Maybe this patient has come to over here, CT brain and CTC spine needed to be done. So, what are the key questions that you wanted to ask in a patient with head injury? You got this lady with head injury. You told me certain things. So, what are the key mechanisms? So, one is mechanism of injury, how much height she has fallen down. The next.
Any LOC is there.
LOC, okay.
Followed by any tonic movements. Or
most importantly, just go to the mechanism. You already told me whether helmeted or non-helmeted. Very important, helmeted or non-helmeted. Any direct impact of head into the floor. Again, very important thing. Then post-traumatic LOC. Post-traumatic seizures.
Any ENT bleed.
Any ENT bleed.
Any multiple episode of vomiting.
Any multiple episode of vomiting. Most importantly, next is that what again history I am asking. Any drugs. The patient is on any drugs. You should never miss. If the patient is on any drugs, she was on any medications.
Thyroid medication and antihypertensive medication.
What medication you will be more concerned? Simple. Which medication?
Antiplatelet and
Antiplatelets and anticoagulants. Any antiplatelet or maybe anti-epileptic also. Now, my question again here really, whether you wanted to put her on a seizure prophylaxis or not.
Normally in head injury, with severe head injury, there is seizure prophylaxis needed less than
So my question is for this patient, mild head injury, you wanted a seizure prophylaxis or not? Yes or no?
No, sir.
No, then you should tell me an answer. Why no? Why you don't want to?
Guideline.
No, as per guideline, yes, I agree that as per the guideline you don't know. So what is as per the guideline that is telling you no? So rather than asking this, where all you give seizure prophylaxis?
A severe head injury less than GCS.
Moderate you won't give.
Moderate.
Maybe moderate to severe head injury, maybe you have to think of giving it anti-epileptics. Then it is very easy, no? You are a witness seizure at any point after the injury. Definitely you need to give. There is no doubt that you should not be giving. Whether there is any witness seizure after the insult, yes, you have to give an anti-seizure prophylaxis. So in general, this is what you need to remember. And again, it is when you say seizure, for this sort of seizure, you don't need to continue for a long time. Like what do you do for our normal seizure disorder mechanism? Maybe after like 2 weeks or 4 weeks, you can think of stopping the anti-seizure medication. So that is again important. And again, most importantly, what is the type of lesion that the patient has developed? If it's a deep depressed skull fracture, which is going and irritating the brain, definitely that patient needs a seizure prophylaxis. Maybe a diffuse subarachnoid hemorrhage, it is not going to create much problem. When it's a subdural or a brain contusion, it is more chance of having. So it depends upon what type of lesion the patient is having following that. But in generally, what you need to remember is that moderate to severe, you can think of starting a seizure prophylaxis. And mild, you don't need. For this lady, we don't need any seizure prophylaxis. And anytime you have witnessed a seizure after the event, we need to start the patient on a seizure prophylaxis. So what seizure prophylaxis? What are the recommended 3 drugs?
Benzodiazepines.
Seizure prophylaxis.
Anti-epileptics, levetiracetam, phenytoin.
And fosphenytoin and lacosamide. So these are the 3-4 drugs. If you say phenytoin, fosphenytoin, they are all the same. So Levipil, fosphenytoin or phenytoin or lacosamide. So these are the recommended agents, but preferably we start either on levetiracetam and orange. One more history that I wanted to, any intoxication. Head injury, another important that you will ask for any patient, but whenever you have a head injury patients, these are the 5 or 6 key questions that you need to ask it, and you can from this history, yes or no, then you will know what type of injury that you are anticipating. So again, alcohol intoxication or any other intoxication is there or not. One mechanism of injury, whether the helmeted or non-helmeted, direct impact to the LOC, seizure, vomiting and further episodes of any headache or anything. Then what else is important? Any drugs the patient on and the patient is on any intoxication at the time of the event. So, and key medical histories, anything, key significant medical history that you wanted to know in this patient. So that is what initially. So we have initially evaluated her and we have taken her to the CT. Now, as an ED physician, you are seeing this patient, okay? So my call is like you said, the GCS of 14. So the patient is being about to shift for CT. So now the sister is coming and telling you the GCS have dropped to 12. The GCS have dropped to 12. So what will you do at that point of time?
At that point of time, if the
CT is not been taken, my scenario, I will explain it again. CT not been taken, you are about to shift for the CT, but there is a GCS drop of 2 from the baseline.
Then I will check the any signs of elevated intracranial pressure.
Okay.
We'll check the pupils and any vomiting, headache or altered sensorium.
Altered sensorium I given history, not 12.
Then hyperventilate the patient.
Protect the airway.
That should not be done. That is an important thing that I want to tell you. Do not hyperventilate. Hyperventilation is not needed. Electively
intubate the patient and protect the airway.
Electively intubate the patient. So again,
drop in GCS is 2, so we will have to plan for some intervention also.
Okay.
And
so drop in GCS 2 in the GCS. Again, I wanted to ask you a few questions. where is the drop? Whether is there in the eye response, whether it is in the verbal response, whether there is in the motor response. So where is the drop is the most important thing that you wanted to see. So which one is more important? Everything is important. I am not saying that one is not important, but which one will be more concerning? So someone was very much active, alert, and openly on the eye, and suddenly eye response is and eye and motor is what I'll think it is more important in this scenario. Eye and motor response, especially when motor from M6 it is going to M4. It is very drastic. So if it is drop of 1 in eye, 1 in motor, okay. But there is a sudden drop of 2 in one of the thing. That is just motor from 6 is suddenly dropped to 4. Motor from or eye response from 4 it has dropped to 2. Or verbal response is suddenly dropped. But verbal response we cannot say because she is an post-ictal, maybe for not post-ictal, confused a little bit of during that time. Maybe she would have come and dozed off also in between. So best thing will be to look for where the drop has occurred. So as you said, we have to look in for, what we'll do, we'll reassess the primary survey. That is what we have to do. Reassess the primary survey and reassess the vitals. And among the vitals, what is the most concerning vitals that you will have? Again, it is in the circulation and that is your heart rate and your blood pressure. You said previously the heart rate was around 97. So if you want to see whether the heart rate have dropped or not, the heart rate is maintaining 97, okay, you are a little bit happy, okay. There is no much signs of raised ICP, one thing I hope. Then the next thing is that 130-70. 130-70, if it goes down, also I am concerned. If it is increases, also I am concerned. Why?
ICP elevated, there is Cushing reflexes, triad is there with hypertension, bradycardia and irregular pattern of
okay, so the BP is 130-70, now it is 160-90.
So
I am concerned. But BP is 90 over 60.
Hemorrhage.
Again, I am concerned because of the hypotension, the patient would have deteriorated. So the cerebral, something has happened to the brain. So that is the only thing. Whether the lesion has increased or the perfusion to the brain have decreased, we don't know. If there is because the patient had an external hemorrhage, bleeding from outside. So at that time, what do you need to do? It depends upon the scenario. If BP is like 90/60, we need to give fluid. So what is the target blood pressure that you want to maintain?
More than 100, systolic blood pressure more than 100 and MAP is more than 80.
Okay. So which all age groups you wanted more than 110?
Adult and
Less than 14, more than 70.
More than 70 and less than 40, 15 years. 15 years and more than 70 years you maintain, little bit on the higher side, more than 110 is the systolic BP. So whether we have achieved the target, I need to achieve that. If it is high also, as you said, it is concerning because we are thinking of raised ICP. Then what else you want to look in for? Breathing pattern of the patient. So what are the breathing pattern, different types of breathing pattern that you can anticipate in a raised ICP?
Irregular breathing pattern, that is normally abdominothoracic.
Rather than the pattern of abdominothoracic, the rhythm of breathing is which I am more concerning. Whether there is a lot of apnea time followed by tachypnea, apnea followed by tachypnea. So that is what we need to look in for. So that is again very, very important. There are different chain stroke breathing, bitot breathing, each one. But you cannot, sometimes in the ED it is very difficult to say which type of breathing. But most importantly, the rate and the rhythm is very important. Don't just look at the rate alone. So the rhythm is also very important. Suppose you are seeing a patient, like in every 1 minute, sometimes he is taking 8 breaths. 8 breaths is very low, 12 breaths, 15 breaths. Then suddenly it is dropping, waxing and waning. So that is again very concerned. So you don't get that much time in the ED, to be very frankly speaking. Then the next thing, you will go and check the pupils. Definitely you will look at the pupils and look for any asymmetry. And again, it is always good that if there is hypotension, you get a fast immediately also. Because initial fast might be negative. Maybe the patient would have started losing blood only. When there is hypotension. When there is hypotension, I am not saying when there is hypotension. Next, whether you wanted to do any pharmacological interventions at this point of time. My 3 things that as I concerned is A, I didn't say, and B, oxygenation was 98%. If it is dropping, yes, you need to supplement the oxygen. If it is falling less than 95, you supplement the oxygen.
More than 90 to 95 is maintained.
Then it is okay. So what else you wanted? Any pharmacological management you wanted to start?
As per a pre-medication, we can give injection GCS drop.
This is a scenario, the GCS of 1 drop has occurred, 2 drop has occurred for the patient, and the patient is about to shift to the CT.
For BP,
Pupils, there is no change.
No change.
BP is the same, and heart rate has not worsened or increased or decreased.
3%.
No. My question is that whether you wanted to do or not. That is only my question. Yes or no? You said regarding hyperventilation, which you should not be doing. Hyperventilation, and again intubation. Within half an hour, there is a true drop of GCS. Within half an hour, there is a 2 drop in GCS. But 12, I can wait. I will not say that you should go and intubate. But if the patient has got multiple episodes of vomiting, then yes, definitely yes. Even if the GCS is 12, you need to go ahead and intubate. It all depends upon individual patients, how the airway patency can be maintained, or there is any chance of aspiration is you are anticipating. So 12 GCS, technically speaking, no need to intubate, but 12 GCS, the patient is having multiple episodes of vomiting, she is becoming a little bit more and more drowsy, no need to wait, go ahead and intubate the patient. So again, the scenario, you didn't answer me whether you want to give any drugs or not.
Antiemetics.
Maybe antiemetics you can give then. Preferably, we can just wait for the CT again. 3% saline, again, it is not going to give you a drastic result within next 20 minutes.
And
Mannitol. Yes, mannitol. So when you will use mannitol? That is the answer that I wanted from you. You said it now. Mannitol. So when you will give mannitol in such a patient, this is the scenarios that you will face. So whether you want to give mannitol or not.
Not for this.
means signs of ICP is there, one can give mannitol.
So when you will give mannitol?
Signs of ICP with
Yeah.
herniation signs. We can
You have to definitely you can wait for mannitol, but your CT is going to get delayed. Okay, there is no in a different setup. I'm giving you a different. You are in a pre-hospital setup, or where you are in a hospital where there is no CT. Facility is not available. You need to shift him after 1 hour only. You are going to get a CT. So within 20 minutes there is a drastic drop in GCC. In that scenario, there is no harm in giving mannitol. But in our setup, we wait for the CT, and maybe we can look in for whether depends upon whether you can continuously monitor the patient or not. Again, hyperventilation is not an option. Hyperventilation, I will tell when it is the last resort. It is the last resort. It is the last resort when you have taken the patient, you have given mannitol, you have treated everything, 3% saline, you have ventilated, you have sedated the patient, but still patient is having features of herniation, you are shifting to the theatre. Till that time, you have to just buy some time. So that is only time that maybe as the last resort, you maybe go for hyperventilation. That too, what you will target your PCO2.
30 to 35.
It is again low normal only you want to target. It is not like below 30. It is low normal. What is you wanted to target? Okay. So now let's see what happened to the CT of this patient. What happened to the CT of this patient? We have shifted for CT.
There is left Sylvian fissure, SH is there, and multiple contusions.
Okay.
SH in the right Sylvian and left high frontal region.
Okay.
And multiple hemorrhagic contusion seen in the left and right centrum semiovale.
Okay.
With the left inferior frontal gyrus.
Okay. So this is directly that what the impact has given to the brain. Direct impact, because of the directly head have gone and hit the patient. The same patient you have taken back, now she is in the ED, you have know this is her CT findings. So now how will you proceed?
And in this case, normally in SH is there, if there is more than 10 millimeter thickness, in this case,
SH? More than 10 millimeter thickness. That is for your subdural hemorrhage that you are telling. More than 10 mm thickness, more than 5 mm of midline shift, you have to take for emergency neurosurgical intervention.
SH, we can start with the normal saline 3%, and keep the vitals like saturation more than 90.
Only thing what you need to do in this patient is maintain airway, breathing, circulation. Avoid hypoxia, avoid hypotension, avoid hypoglycemia, hyperglycemia, avoid hyperpyrexia. That is the only thing you wanted to do. Masterly inactivity. That is you have to do. Don't do unwanted things. Just observe the patient. And if needed, maybe seizure prophylaxis in and out, because there are a lot of contusions. That again, looking at the image, maybe a seizure prophylaxis. And just monitor the patient. Maybe 3% saline you can start if there is edema features. Otherwise also, just wait, give her good analgesics, observe her, avoid hypoxia, secondary brain damage, avoid hypotension, avoid hyperthermia, observe the patient and look for other missed injuries if you have done anything, if you have missed anything. So that is only would have been done for this patient. Nothing else would have been done. Neurosurgery would come and see this patient and just admit it in the case. She doesn't require any intervention. At present, nothing. When will you repeat a CT for this patient?
GCS drop.
Whenever there is a GCS drop or whenever there is a vital parameter change, you can ask for a CT. Then routinely, maybe after 6 hours, maybe it's a pretty early CT that you have done, maybe within 6 to 12 hours. That's all depend upon how the clinically the patient. You can ask for a repeat CT to see what.
Any increase of the hemorrhage?
Okay. And increase of any new things that have developed. What are the new things that can develop in her? So what she has developed is more of an coop injuries.
Counter coop.
You can have counter coop injuries. So counter coop injuries will not come immediately. So you have to look for that also. So look up maybe after 6 hours you can look for all those things. So this is what direct impact I have done for her. And maybe because of the brain, what is counter coop and coop injury? Because if the brain is hanging in the cerebral spine of fluid, suppose there is a hit, there will be opposite side also, there will be a pressure effect that would have happened due to that force. So you have to look for a coop and counter coop injury. So that's what you wanted to do. You call the neurosurgeon, see there is a patient with head injury, mild head injury she has come with, she needs to be admitted for observation. Technically speaking, nothing needed to be done, maybe suturing needed to be done if you are not done initially for the wound. Tetanus prophylaxis, depending upon whether it's a tetanus prone wound or not. Pain management and her general conditions, whatever she's medication she's on, you need to restart on those things. No role for nemodipine in traumatic SAH. No role for nemodipine. If it is a non-traumatic SAH, yes, nemodipine can be given, but here no role for that. Seizure prophylaxis, that's what I said, plus or minus. So what are the medications given for her?
3% NSO started,
Okay.
conservative management, antibiotic given and TT given. Now it is CT again taken, is resolving. So
She can be discharged home. That's it. So only problem is that you have, well, it's an SDH, EDH. Then definitely you have to monitor more than, that's what you said, more than 10 mm thickness, more than 5 centimeter, 5 mm midline shift, then any drop in GCS. These all candidates requires an ICP monitoring also. So when it's a severe head injury, make sure that this patient needs an ICP monitoring. Intracranial pressure, maybe you need to put an catheter and you need to monitor those things. But in general, as any head injury victim, the majority of the time they will deteriorate because of the problems that can be easily treated, like preventing hypoxia, preventing hypotension, preventing hypoglycemia and hyperthermia. So avoid secondary brain damage. That's the best thing that what we can do to prevent the brain from getting a secondary insult. Already there is an insult due to the trauma. Avoid that. That is holds good for all your stroke, any head injury, any CNS patient. This is what all we need. Just observe. And tranexamic acid. Maybe we can, initial bleeding was there, maybe a 1 gram tranexamic acid could have been given. Initially 1 gram Tranexa, and maybe 8th hourly you can repeat one more tranexamic acid, and the patient is on any anticoagulants and all, then we need to think of giving the other reversal agents also. So that's it. Anything else that you want to add on? Okay, thank you.